ready for this? Y'all ready for this? Y'all ready for this?
Welcome, everyone. Thank you so much for attending our first There's Always Hope 2-day learning series on substance use during pregnancy and the postpartum period, recovery supports, shifting power to family-led service delivery, and what we are hoping will be a community building event that acts as the catalyst to redesign and transform our community for families. We're going to start right away to maximize our time. Please note that these sessions are being recorded. This learning series was created to provide a learning and awareness space, a container for community building within the workforce that is tasked for caring moms and babies. Like our title says, there's always hope, and the process of recovery is not always linear and can definitely be messy. I want to take a moment first to thank BBHC for awarding Broward Healthy Start Coalition with funding to establish a behavioral health program designed to support pregnant and parenting persons that are experiencing substance use. This program cannot do it alone, and we depend on our partners, such as all of you that are here today, being in authentic, accountable, and right relationships with all of you is how we do the hard work. I'm not going to spend time today pulling any graphs, sharing data charts with you. We do that all the time. Just so you know that every year in Broward County, the number of births happen to be decreasing. However, the number of babies born substance exposed to a substance are increasing. So we ask ourselves, how do we get in front of this? How do we make an impact? We feel we have not only a useful agenda, but a necessary one that will spark the necessary conversations and introspection. Before we kick this afternoon off, let's review a few group agreements that I hope everyone in attendance will be more than willing to resonate with. The first, we agree that we will respect the process. Two ways that we can do this is by being committed and engaged, which includes having your cameras on when possible. We know emergencies and phone calls happen, but we ask for the short time that we are together that we remain present. Next, we will listen respectfully and respect the confidentiality of those presenting and those who wish to contribute to asking questions, comments, and any visions with the group. Next, we agree that everyone is willing to feel uncomfortable and be able to manage those uncomfortable feelings if they do arise and seek any additional support if needed. And lastly, but very, very important, we want to recognize and agree that as a community, that substance use is a brain disease, a behavioral health disorder, meaning it is characterized the same as any other disease like diabetes or hypertension. It's chronic, progressive, and fatal. It's never a question of morality, not loving our children, and not wanting to be healthy enough to give birth to them and parent. So now we're going to talk about a few minor housekeeping items while we're together. One, we are asking that everyone stays muted so any background noise does not interfere with those presenting. Next, if everyone could please type their name into the chat for attendance purposes. Zoe Warner and Samantha Silver are going to be making sure that everyone who is here is noted in order to present you with a certificate of 4 hours of learning services completed. Because we do have such a large group, we are asking that everyone use the chat function as a way to ask any questions, have any comments that they want to make. We want to make sure our content is covered. The chat is being monitored by our team, and if there's time, the questions will be answered at the end if they aren't answered by the presenters during the presentations. Either way, we will be sending out the questions with the answers to everyone at the end of the training. Both today and tomorrow's sessions will be recorded and will be available on the Broward Healthy Start YouTube page for future access and sharing. We will be using the function of a breakout room. The instructions will populate automatically on your screen to enter that breakout room you are assigned. Every breakout room will have the same question to answer, and the question or scenario will be posted in the chat prior to being assigned a room. Please let us know if there are any questions on how to use this function so you can participate. Last, but certainly most important, we hope that you never forget that even in the darkest of moments, there's always hope. So with that, now what you have truly been waiting for, I am fortunate enough to introduce today's presenting dream team, as we call them here at Broward Healthy Start Coalition, Dr. Claudia Vicencio, Dr. Alberto Ogson, and Melina Rodriguez from Memorial Healthcare System Outpatient Behavioral Health. We are grateful to have this amazing team here with us today. Healthy Start and Memorial have developed a true partnership, and I can tell you there has never been a time that I personally have not learned something new when in a meeting or presentation with this team. They are the definition of subject matter experts on substance use during pregnancies, and they are warriors in the mission of creating a safer community for babies and their families. This team is passionate about helping others, raising awareness, and being advocates for people's wellness and recovery process. So with that, I welcome the Memorial team.
Thank you, Stephanie, for such an awesome introduction. We definitely have a true partnership, and I'm going to let the rest of the team talk, but I'm just very, very happy to be here today and really looking forward to this presentation.
I'll go next. I saw a few comments from folks regarding audio. Hopefully audio is fine on your side. And if you are having audio issues, just turn up the volume. But besides that, we're very happy to have you guys join in. I am Dr. Augston. I'm a board certified psychopharmacologist, and I'm a board certified toxicologist. Dr. Vicencio and myself have been doing many things to address the various impacts we've had in the community since 2015, really, and it doesn't really end related to the opioid epidemic and now fentanyl and so forth. There's many things that we've been handling and dealing with. Mm-hmm. And then, and at the end of the day, we hope this presentation sheds a lot of light and educates the folks that are tuning in. And if you have any questions, feel free to ask. We're here to educate, here to spread the word. And I think that one of the things that you'll get from what we do and what we present is that we actually have a big heart and we care a lot about what we do.
But okay, listen, I can't work.
And if we can have everybody mute that's on the call, so we can make sure there's no interruptions. Melina, you want to introduce yourself?
Hi, my name is Melina Rodriguez, and I'm currently the MIR navigator for the program. I'm currently a licensed mental health counselor, and I'm very honored and pleased to be here and to work with Dr. Augston and Dr. Vicencio.
Thank you. Dr. Vicencio, I'll let you kick it off.
Okay, great. So we're going to get started. I think what we have is we wanted to take a sort of broad approach to what we're doing and give you sort of a foundation and then a lot of specifics on our program and what we do. We also have a case study at the end, and we're going to give you guys time to go into breakout sessions and to discuss amongst yourselves what steps you might take. And then we'll wrap it up when we're finished with the small group discussions. We'll talk about our process and what some recommendations. So we'll be able to have a larger discussion and a wrap up. So again, thanks to Stephanie and Sam from Healthy Start, and hopefully that you guys are going to find this useful. If you have any questions as we're presenting, I think put them into the chat, and then Stephanie, maybe you could just like pop in with the questions so that we don't have to manage them as we're presenting. Would that be okay? Great, thank you, I see you. All right, so for us, integration is the name of it. Not provide services to a complex, I think any vulnerable population or any complex population, but especially pregnant women or women who are, recently postpartum. So we included this slide, or kind of kicking it off with this, because of the idea that we are part of a multidisciplinary team. Not only are we working as a hospital system, working with an outside agency, but we're also working as people with different types of education that are coming in with a different perspective and maybe a different relationship with the client, but that all of us working together really are the ones who can make a difference in terms of the success of the birth and how a mom is able to get the help that she needs. I don't know if Melina or Alberto would like to add anything to that, or Dr. Augston.
I think the one thing that I would add to the focus of integration, I think the one thing I would add, and as I educate the different disciplines, and I spend a lot of time educating different disciplines from medical, nursing, pharmacy, social work, peers. My biggest message is that you'll be surprised of how important any one individual role is in the multidisciplinary team. And my biggest emphasis is that there's a lot that can be done. I think for those individuals that really care about what's happening with our patients, and hopefully you can empower yourself to know that when you leave today, whatever knowledge you get, that you do have a role, and hopefully you could bring that to, at the end of the day, help your patients get the help they need. So I think that's the biggest take-home message with this.
Excellent. And I 100% agree with you. So wait, hold on. Okay, here we go. So the people that we work with in general are people that are impacted by something called social determinants of health. And I don't know if anybody on the audience has heard of this term, but it's something that we're talking about more and more, especially in healthcare. So social determinants of health wanted to include this here because it really shapes the way that people access services, especially medical services, and if they are, it could prevent somebody from accessing services, or once they're engaged or they've accessed services, prevent them from fully engaging in services. And a lot of the work that Healthy Start is doing is actually reducing the negative impacts of social determinants of health. Things like health literacy or mental health literacy, like what services are out there? What does it mean that I'm having the symptoms? Can I detox on my own if I'm, using heroin and I'm pregnant? So some of that would be like, that would fall under that category. What kind of opportunities does that person have? What kind of access to food? Do they live in a food desert? Do they have transportation? These are all of the sort of quality of life issues that really impact how people use and are able to access treatment. Melina or Dr. Ogston, anything to add on this?
Yeah, I mean, I'll add a few things. For those, and when we do our presentations, there's a lot of things that's included. And sometimes it becomes a topic that you haven't seen before, been educated on. I think the social determinants of health is something that's rather new, especially in the last decade, understanding it. I was actually new to this topic in the last 5 years. Dr. Vicencio educated me a lot on it. And at the end of the day, it impacts the care we provide for our patients in all aspects of life. It doesn't matter what disease state we're talking about. So once again, another opportunity for those that maybe you're looking at this, you're like, I haven't seen this, and understanding this can really have a huge impact on how you realize the different deficits that some of our patients have and access to care. So that's how I look at social determinants.
Thank you, Dr. Ogston. Yeah, and again, this is we wanted to include this here because it's something that you'll be hearing more and more. And know that if you're working in the community, if you're working with people in the home, you're actually doing work that's going to help improve some negative outcomes related to social determinants of health. Okay, so this is a slide that we included, and again, we said we would start broad, and we are starting really broad, and we're going to scope in more specific as we move through the presentation. But this is something that we like to start with because right now we're still in the midst of an opioid crisis. I'm sure that we can add about 5 years to this slide, and we can talk about where we are now. But Dr. Ogston, would you like to take this one?
Yeah, I'll definitely take it, and a few of the other ones coming up. And so from the slide itself that you're seeing, many of you have probably seen this slide, but let's focus on what we're showing. On the y-axis, you're seeing deaths per 100,000 population. On the x-axis, the year, wave 1, 2, and 3. And I think most of us know at this point that we had a serious epidemic related to opioid use. We had pill mills and everything that happened. And then you see the closure of those pill mills with legislation. and a subsequent now that going from the impact that that had related to deaths to changing folks to heroin. And then in 2010, you see the rise of heroin related deaths. With that, I'm sure you guys are aware that it correlated with an increase in HIV, a correlation increase in hepatitis C, other things like infectious, like osteomyelitis and myocarditis. And then you see the third wave related to synthetic, which you guys know is fentanyl. And I don't know how many of the folks that are on have heard of the real rise that we're having with fentanyl. Because this is what you saw. We saw this rise happening in 2013 with synthetic. But the graph you're seeing doesn't even depict what we're encountering. And whatever data that we even have to display isn't up to date. And I'm sure many of you guys have heard the stories that now we're having pediatrics affected, right? We're having young adults, younger than 18, being impacted. And if you understand the philosophy of why somebody who's producing some of these products would put fentanyl in cocaine, fentanyl in alprazolam, or Xanax, and fentanyl in everything, it's naturally because you're going to now create users, right? And not only are you creating that population, you're creating them at a young age. So, you know, it's something that before what we saw in the last 2 years when we presented this, it's very drastic. You see that rise in synthetic opioid related deaths drastically going up. It's even worse now. And I've talked about this, I've been interviewed related to this philosophy, and just the fact that we know we've seen more fentanyl related deaths in those younger than 18 than from COVID itself in the same time frame is scary. And the fact that we see deaths related to fentanyl in those that are non-opioid using, meaning 85% of the deaths related to fentanyl are in those that are using other products. Hence, they're getting exposed because they're using cocaine or alprazolam or whatever have you, I think speaks very loudly. So this slide was very powerful years ago, but now it's even more powerful and it's not even up to date. So I think that's my biggest take home message with what you're seeing now. Go to the next slide. Yeah, that's all you.
So we're in the middle of this crisis. I think that, like, as Dr. Austin was saying, the confluence of having increased fentanyl in the illicit drug supply and then it being distributed amongst not just now heroin, but other drugs of abuse, such as, you know, fake Xanax, alprazolam, and things like that. You have that together with everything that happened during the pandemic. There was a decreased access to emergency departments because of, you know, what was going on with COVID. We're still doing our absolute very best to, you know, help people get the treatment that they need. And as Stephanie was saying, you know, with reducing the number of babies who are born substance exposed. So that is something that we've been working on since 2015. Obviously, we have not fixed the problem yet, if there's such a thing as being able to fix the problem. But there are strategies that work. And I think having sessions like the one we're having today and the work that you are doing in the community goes a long way to that. So what are the strategies that work? We want to make sure that there's an access to medication assisted treatment, right? We want to make sure that people, if they want treatment, are able to access. In our program, we use buprenorphine with pregnant women, so it's Subutex, and then Suboxone with non-pregnant populations. But the idea is, how do we make treatment, making sure that that treatment that's so necessary is accessible, but also understanding that that treatment is not everything, right? There has to be behavioral component. There has to be a whole recovery-oriented system of care that goes into place in providing support to that person with a substance use disorder. The focus has to be on keeping people in treatment, right? How long do we keep them in treatment? I think we're going to talk later on about this issue of detox versus, MAT, or what is detox in the continuum of treatment. So the idea is that it isn't like I go into a place for 3 days, I'm done, and then now I'm clean and everything's fine. The idea is that we want to help people stay in treatment and encourage them to stay in treatment as long as necessary. If they do relapse while in treatment, we understand that that's part of the process of recovery, and that we don't judge people or kick people out because of relapse. Involving healthcare professionals is really important, and this is why these partnerships, like the one that we have with Healthy Start, is so important, because we're not just looking at addiction as a thing that exists in and of itself, but we look at what other behavioral health conditions are going on. Are there any medical issues? How many, and then of course, in terms of a pregnant woman, you're working with OBGYN. You can't have, for us, our Mothers in Recovery program would not exist if it wasn't in partnership with maternal fetal medicine. Looking at, I was saying, depression and suicidality, this is something that needs to be always considered and dealt with in terms of treating people with substance use disorders and other, obviously, mental health conditions. And then looking at prevention. So how are we screening people for potential substance use disorders, especially, in the terms of pregnant women, which we're talking about today. So those are strategies that work, and you'll see how we put a lot of these strategies in place through our programs. I don't know if Melina or Dr. Austin would like to add to the slide.
No.
All right, so Dr. Austin's going to take it away with his brilliance. Everybody strap on your seatbelts. This is going to be awesome.
Yeah, well, so thank you. I appreciate the brilliance comment. But I did want to say one comment about the data before. Pardon me for my voice. My one comment is on what have we been doing for all these years, right? And I've been in multiple community meetings, and I've been doing so since 2016 when the funding started for MAT. And Dr. Vicencio and I, she knows me, and I always challenge the community, and I challenge myself. What are we doing? What are we doing different? We have a significant amount of funding for MAT. We have a significant amount of access to programs. We have a significant amount of prescriptions. In the early days, 40 years ago, with methadone, now Suboxone and Subutex, right? And yet we have an out of control epidemic. So what have we been doing? And I think that one of the key words that Dr. Vicencio mentioned, right, is comprehensive program, right? A program in which you're not just providing a medication that takes over the need of the addiction of the opioid. It's not so simple. So the comprehensive piece is crucial. And at the end of the day, if we are in the midst of this epidemic, and now it's affecting our pediatric population, as pediatric populations become adults, those adults keep on using, we keep with the deaths rising. The question is going to remain, what are we doing different? Are we just going to add more money? We're going to add more MAT. We're going to add more medications. So I think it's good to reflect on, there is a difference between the quality of the programs that your patients go to. There's a stark difference in that. And I'll give you some statistics. For the patients that come into our primary hospital, we engage approximately 60% of those patients into treatment on day one. That seems like a horrible statistics, but it's probably closer to 10% outside of our healthcare system. Out of those 60%, about 60% of those will go on to the next level of care, meaning we lost 40%. So knowing that data is important. And the question is, what are we doing to improve our process? And that's what we all should be doing. So that's just my little pet peeve I wanted to make sure. But now let's jump into the reward pathway. And the reward pathway to me is just a fundamental piece to understand what your patients are going through, what you go through, what we all go through when it comes to something that's rewarding. We've all experienced it one way or the other. When you're seeing in front of you somebody doing a line of cocaine, chocolate cake, and you're seeing on the left-hand side a little diagram And on the right-hand side, something that says activation of reward pathway by addictive drugs. The reward pathway is made up of an area in the midbrain called the nucleus accumbens and the VTA, which is the ventral tegmental area. At the end of the day, anything that activates the reward pathway, whether it's a substance, right? It could be illicit. It could be illicit, meaning you have a prescription for it. It could be a chocolate cake. It could be sex. It could be alcohol, right? Gambling. When it activates the reward pathway, it causes the release of dopamine. The release of dopamine makes one feel good. It makes one feel potentially euphoric. And that is very rewarding. Go ahead, Claude, go to the next slide. So here's another diagram, different things that activate the reward pathway. I mentioned already, it could be anything and anything that to you is rewarding, right? As an individual. I often want to say, how do you separate out the significance of how much dopamine is being released? And I always give this depiction. Imagine if you activate the reward pathway and you activate it with a piece of chocolate. Yes, you might have some dopamine release. But now what happens if you activate it with some cocaine? The amount of dopamine release is much more. It's a significant amount of dopamine that's being released in that particular pathway. Next slide. What you're seeing here is something called conditioning. And I'm going to describe it so we can really break it down. As you have activation of the reward pathway, which is very central, right? It's one of the most central behavior mediated pathways that's old, intrinsic into the body, and any animal has this pathway. By activating that pathway, right? I mentioned you have the release of dopamine. Dopamine makes you feel good. You can have euphoria. Followed by euphoria, you start to develop what's called conditioning, reward cues. And that then causes an area of the brain called the amygdala. And in front of you, you have the amygdala on the left-hand side, a little neuron area. And the amygdala learns the experience, learns the reward, right? It's something that essentially the amygdala will almost engrave that experience and memory as something that is euphoric in nature. It feels good. And I often give the example, if one is using, right, any substance, but let's do something that's common, something difficult to stop. How about nicotine? And you have a smoker, you know, they're exposed to nicotine, and nicotine becomes addictive, it's rewarding and so forth. And they get used to smoking a cigarette. And this individual typically smokes their cigarette, and they smoke their cigarette, and at the same time, they typically like drinking a can of Coca-Cola. And I've given this example many times. As you have this amygdala learning your reward cues and so forth to conditioning, what would happen to that individual if they walked into a room, they're not smoking at the moment, and they see a can of Coca-Cola standing somewhere on the counter? Immediately, without even knowing it, the amygdala is going to be triggered, identified of that Coca-Cola, and it's going to actually recall the cigarette. And it's going to actually cause a little bit of dopamine to be released into the reward pathway, right? It starts activating the reward pathway immediately, wetting your brain and mind to saying, I'm craving my cigarette. And until it has a cigarette in hand, it will continue to trigger you to say, I need to have my cigarette. You go to the next slide, Phil. Let's go back one because we didn't include it. So now the question becomes, how do we combat these cues, these triggers? And all of us always speaks to this. We all tell each other and tell our patients and so forth, right? People, places, and things. And it all stems from that, right? So things are so easy to get rid of these things that potentially we're using. If it's something you use with some item, some whatever it is, eliminate that item. Places, if you typically use in a particular house of friends, a location, or you would use after going to X events, we stop doing that. People is very challenging, right? Because a lot of times people associate or use with individuals that are maybe very close to us, especially if there's a couple involved, right? Essentially, how do you get rid of that? It's very challenging if you want to stay in that relationship. So people is very, very challenging. But lastly, one of the things that's important to know, what is it that helps you overcome this learned experience? And the answer is the prefrontal cortex. The prefrontal cortex, right, is what allows us, right, higher level thinking humans and mammals to be able to say, I'm going to reason and I'm reasoning. That's great. Yes, I see the Coca-Cola. I feel the dopamine. I feel the urge and craving to smoke. But I now have enough experience and lived experience and enough negative experience to know, you know what? I've already given that up. And I don't want to, because I'm at risk for cancer, because of the way my breath smells, because of the way my hands smell, because of the impact it has on my children, X, Y, Z. You start reasoning. And the understanding of the prefrontal cortex is very challenging, because one of the things that you realize is the prefrontal cortex is something that develops. And very interestingly, you have the two greatest times in your life that you will have the greatest growth of your prefrontal cortex. That's from age of birth up until age 1 or 2, right? When you have these babies starting to walk, and what happens, they fall because they're top heavy, their heads are very large for their body. And the second age, right, is young adulthood. The young adulthood, where we know the prefrontal cortex finally starts to fully develop by age 25. To be able to handle and reason the challenges that we face. But it turns out one of the things that you realize, something stops the full development of the prefrontal cortex. And what is that? The use of any illicit substance. Long-term use of illicit substance prevents the full development of the prefrontal cortex. Hence, while some of you may have a 30, 40, 50-year-old individual who has a history of substance use disorders, who has the prefrontal cortex of somebody that may still be in their teenage years, somebody who's unable to reason, who has impulsivity issues, all secondary to the use and history and development of the prefrontal cortex. Now, one of the things that we've learned is that the prefrontal cortex can fully develop and continue to develop if you stop using these substances. So that's the silver lining. Anyways, very interesting topic. And we'll go ahead and go to the next slide, which is a completely different topic. I don't know if you wanted to say anything, Dr. Vicencio.
I wanted to just thank you for breaking that down the way that you did. And then obviously the silver lining, which is the idea of brain plasticity, right? So that sometimes people get all of this information and they think, am I doomed? And the answer is no. So we always believe in recovery, and that recovery works, and what it takes is time. So as we put all of these measures in place to help people recover, have them associate with new things, maybe go to school or get the degree that they've always wanted, or reconnect with family. Those are the sort of, creating new neuronal pathways that can foster growth and development.
Yeah, that's exactly right. So let's jump into the idea of toxidromes. This is a very complex topic, and I know we've gotten used to having these meetings over Zoom and any video conference. I love talking in person because I get to I get to move around, I get to animate, and I get to see your face. I get to see if you're actually paying attention, or if you're on your phone, or if you're ignoring me, making faces, and half of you may be doing that right now. But so I'm going to talk about toxidromes. And this is probably very foreign to the majority of you. Toxidromes is a way that toxicologists use to identify people who are presenting in an emergency setting, and to identify what potential substance they were exposed to. I have a few here in front of me, but I'll give you the classic example that we look for that's very severe and dangerous. We look at things like if you had an exposure to a nerve agent. Many of you guys have probably heard of nerve agents, and you've heard of some gas that could kill a large portion of the population. Imagine if that happened and they didn't know. Well, we based off of a toxidrome, we'll say, oh, we know you're presenting with such. We know we have to take immediate action to protect you and the people around you. So the same thing holds true in the toxidromes when it comes to the use of illicit substances. And many of you guys have heard of this, right? The most classic is your pupil size. So let's go ahead and describe this so you can understand it from my perspective of what we're dealing with. And we'll go into what you're seeing in front of you, this graphic, and we'll describe the presentation of the opioid. The opioid, third one down, opioid. And I'm sure many of you guys know already, an opioid is any agent, synthetic or natural. And synthetic and natural would be like opium, right? Synthetic fentanyl, any opioid that acts on opioid receptors. So we're going to classify this opioid, and patients who utilize opioids, if you are under the influence of an opioid, you would present with the following. And we're going to go each column: heart rate, blood pressure, respiration, next, temperature, pupils, bowel sounds, diaphoresis, which is sweating. If you are presenting with intoxication from an opioid, meaning you have an opioid potential overdose, you will present with a heart rate and blood pressure that's decreased, respiratory rate that's decreased, temperature that's decreased, pinpoint pupils, absent bowel sounds, meaning they're not moving, and you're dry. Now, really understanding this, when we know somebody has had an opioid exposure and may die, they present with pinpoint pupils, right? Classically, we all know this. Now, why are they going to die? Why is there a risk of death? Because the opioid receptors, right, in the base of the brain activates your heart rate and blood pressure, and it inhibits it, meaning it stops the heart rate and blood pressure, slows it down, and it slows down your respiratory drive, meaning your respiration rate can go extremely low to the point of stopping your breaths. And that's what they die from, right? They die from a decrease in respiration. Now think of the opposite. How do patients present when they're going into withdrawal? So when you are engaging your patients in access to treatment, if they withdraw, how are they presenting? Heart rate, blood pressure rises, right? Respiration goes up, temperature goes up, pupils dilate, they might have diarrhea, and they start sweating. All the opposite. The one thing I'm going to point your attention to is the following. Go one down and look at what's called the sympathomimetic. Sympathomimetic includes things like cocaine, amphetamines, and let's look at how these people present. They present heart rate that's increased, respiratory drive that's increased, temperature that's increased, dilated pupils, they have bowel sounds, and they're sweating. Now ask yourself, we're in the midst of this new epidemic related to this fentanyl. They're putting it in everything, including amphetamines and cocaine. How are your patients presenting to our hospital? They're presenting mixed. There is no clear picture, right? They're opposites. While one's increasing heart rate, one's decreasing, and changing the respiration rate up and down, temperature up and down. Pupils are completely opposite. Bowel sounds, sweating. It's a mixed picture. It's extremely challenging, right? We don't know. And I'm doing this as an example for you to realize that if you're assessing your patient and maybe they're consuming opioids, maybe they've told you so, or maybe they test positive for fentanyl. And at that point in time, let's say their pupils are not pinpoint. It's because they may have other things in their system. So I just want to bring this picture to your attention to understand the complexities of it and understand how you can and can't use something like understanding like toxidromes. So that's a little bit of a complex topic, but I thought it was worth mentioning. Dr. Vicencio?
No, I mean, this is something that we've been presenting for quite a long time throughout the state of Florida, Dr. Oxton and myself. And, this is a topic that is so necessary because there's so many different things that you might be working in the community and you might come across something and you're not sure what you're seeing. So in some ways, it's good to understand what the basics are and then know that because of what's happening in terms of the fentanyl and the drug supply right now, what you might see is also mixed. But, you know, in any case, if you guys are working in the home, I'm sure you have protocols for what to do if you think that somebody may be going through withdrawals. Typically, you would just call 911 and make sure that the person can get the medical help that they need. But it's good to understand these really basic principles, and we find them every time we present on them to be quite useful. So another thing that we always talk about, and I guess this is like the flip side of all of the sort of the toxicology aspect, which is, you know, what is the basis of addiction, or kind of what do we look at in terms of addiction? Is it a morality issue? And, you know, Stephanie was saying, and this is, you know, addiction is a brain disease. But in some ways, this study, I think what it tells you is it's also a social disease, right? So there's addiction studies that they did at Simon Fraser University. On the left of your screen, what you see is a rat in a Skinner box. So they did studies on rats. Some of you may have heard of these studies. Basically, they put a rat and they gave the rat access to water, food, or cocaine. And they also used heroin. And so it was either, you know, one illicit drug, either cocaine or heroin. The rat could press a lever and get either water, food, or cocaine. And you probably heard, but in these studies, the rat just pressed the cocaine lever until it died, basically. In lieu of food, in lieu of water, just use cocaine until it was dead. At Simon Fraser University, the studies that they started doing is, well, they were looking at the environment that the rat was in. So when they did these initial studies, the rat was in a Skinner box. So you can see what the rat's environment looks like. Not able to go anywhere, no, and any stimulation from the environment that was positive. And the hypothesis was, what if we put this rat in a different environment, closer to its natural environment? Would the rat still choose to kill itself with cocaine or with heroin? And so what you see on the right is Rat Park. And there was actually a book called The View from Rat Park that was written about it. But what they did with Rat Park is they created a natural environment where the rats could play, hang out with other rats, eat, have sex, just be rats. And they also gave them the same option of food, water, or cocaine, or food, water, and heroin. And what do you think the rats did? They tried the cocaine or the heroin, but then they never went back to it. So how much does your environment, right? What does addiction look like in terms of what society, how does society contribute to the rampant addiction that we have? And then what are some of the antidotes that we can find? And I think that the View from Rat Park really kind of tells us is this is a solid argument for a recovery oriented system of care. It's a real, it tells us that the more that people can find meaningful connection in each other, the less likely that they're going to kill themselves with drugs. So this is a quote. We use this in every presentation that we do, because we find that it's a real salient point, and it hits home in terms of the work that we're doing. Dr. Alexander, Melina, I don't know if you'd like to add to this.
I don't mind to add a few things. I mean,
Okay.
I think that I think the Rat Park principle is a very good one, and I think it's a principle of hope. Talk about what we're talking about today, right? Hope. And I it's good to reflect on our own experiences. It's good to reflect on the fact that we all have struggles. We've probably all been in places that were dark or challenging. And that's the way we approach it from our patients. I mean, I've seen patients present in places that they were the darkest they've ever been. And then to see years later, the recovery that they've had is wonderful. But we've also seen the opposite, those that drop out and weeks later we find out that they overdosed and died, which goes back to what can we do better? Always, what can we do better? So yeah, so I think that the Rat Park idea is phenomenal, and keeping that as hope, I think, is the main message here.
Sorry about that. Okay, so from Rat Park, and Stephanie or Sam, anything you want to say about what we just discussed before we move into the next part of our presentation? Putting you guys on the spot.
No, we're just in awe of listening to you guys. So you just continue. We're good.
Okay, all right. So wanted to include the ASAM criteria. This is from the American Society for Addiction Medicine, right? And you guys might have heard the term ASAM, but really what the ASAM is, ASAM is has a, it's software that allows you to basically go through a series of really long questions and determine what level of care does that person meet criteria for. So basically it's really to place people in what type of services that they need. Anybody who's worked in addiction in the last 20 years or worked with DCF in addiction has had to fill out an ASAM sheet where you check off these boxes. It's actually a lot more complicated than that, but most of us in DCF requires that we look at some sort of level of placement, level of care, placement tool that we use something evidence-based. And typically there's like, again, this little check off that we've used. Some of you may have seen it, some of you may have not. But the real background behind it is, how do you assess somebody for what type of care, what type of level of treatment do they need? Does everybody need residential? Does everybody need detox? So can somebody get treatment outpatient? So the idea behind the ASAM criteria is that in order to make an assessment like that, you need to look at various dimensions that contribute to the whole picture of the person using. And so this is really, it's a guideline for placement, continued stay in a specific setting, or transfer and discharge. But what you're looking at is number one. So what's the withdrawal potential, right? It's the person just use and they're potentially going to go into withdrawal. Have they, haven't used and again, it also depends on what substance they're using, right? With alcohol, you're going to look at one thing versus maybe cannabis, you're going to look at something completely different in terms of intoxication and withdrawal potential. The second dimension looks at the biomedical conditions and complications. So in this case, we're looking at what are their health condition. Does a person have diabetes? Do they, and if they do have diabetes, is it controlled, or is it, something where the person is continuing to have, or they're not regulating their condition well, they're not managing their symptoms well. In the case of pregnancy, that would go in dimension number 2, right? Even being postpartum would go into dimension number 2, because you would want to consider there's certain medical issues that might go along with that. 3 is emotional, behavioral, and cognitive conditions. So this is what we're talking about. Does the person have depression? Do they have schizophrenia? Or have they had head trauma? So that's where this would come in. Now, dimension 4 is, what are the readiness to change, right? So we talk about pre-contemplation, contemplation, those stages of change is what we look at in dimension 4. And Dr. Austin and Melina will tell you, people that come into treatment, and you probably see it too, they're ambivalent. They're not, people don't come in to get treatment, even pregnant women come in thinking, okay, I'm ready. I'm taking care of everything I need to take care of, and I'm ready to stop using. I can't think of a case where that's actually happened. I don't know, Melina or Dr. Oxen, you can think of it like somebody who walked in the door, ready to stop, done.
I think maybe out of one.
Okay, yeah. And so typically that's the exception, not the rule, right? When we look at dimension 5 is, what's the relapse potential of this person? What is, what's the relationship with their drug of choice? How likely is it that they're going to continue use? And that helps to tell you, do they need to be in a more structured environment, or can they be in an outpatient setting? And then you have their recovery or their living environment. So are they homeless? Are they in a situation where there's other people in the house that are using? Those are the kinds of things that you look at when you look at ASAM. And so the main thing for this slide is for you guys to know that there are ASAM criteria that we use for placement and level of care. And that really looks at everything. So something that you guys may use or heard of is recovery capital scale. that would sort of fit into this assessment. It goes along nicely with what we're talking about in the ASAM criteria. So when you hear ASAM criteria, now you know that you're looking at 6 different dimensions and that it is as a guideline for placement. But so much of what we do isn't just inputting data into a software and it spits out and tells you, okay, this person needs to be in residential. It's also our connection with the client and our ability to properly assess them as a human being that's in front of us, right? Anything else on this, you guys? Okay, so I'm including, we've included this slide. So this is the ASAM, this is the continuum of care according to ASAM, right? So you have early intervention, outpatient, intensive outpatient, partial hospitalization. So as we're going towards the right, the level of care is getting more and more structured, right? So level 3 is residential, right? And then you have services that are medically more intensive. So now medically monitored intensive inpatient services, such as a person who needs to have, because of medical complications or because of, withdrawal potential, they need to be in a more intensive residential setting. What is missing from this continuum of care? What can you do? What do you think is missing here? I'm going to tell you, detox is missing. Yep, that's right. And we use this slide because people think, in the community, generally, detox is somebody needs to get treatment, they need detox. And then that's usually when people reach out to me from the community. They're like, oh, I need to get somebody into detox. Detox is not substance abuse treatment. Detox is stabilizing the person long enough to be so that they can engage in treatment. So people think that, going into a program for 3 to 5 days is enough and then they're good. That's not the reality. So when people are asking for detox, we try to figure out kind of what's going on with the person and then what are going to be the next steps in treatment to make sure that they actually get the help that they need. Detox just stabilizes from a medical perspective. It is not treatment. Dr. Ogston, would you like to add? Melina?
Yeah, I mean, I don't mind to add. I think so. I'm in this field for a while now, and there are folks that I engage with on an administrative level that are well versed in what we do in programs and the impact on our community, and they continue to use the wrong verbiage and terminology, and that's okay because the way I look at it is, you can't change the world. So if you're saying detox, I say comprehensive program that I have, you want detox with my program? No problem. So I try to allow the words to come out however they come out. If there's an opportunity to educate, then we educate. But I think it's the thing we're going to contend with and will continue to contend with because of the misperception that it must be a detoxification. And in essence, you can come at it from 2 approaches. Say, we are detoxifying you, but we're doing it over a longer course of time. And perhaps we'll get to a place that we'll realize that maybe we cannot completely detoxify you. Maybe we have to completely convert you to something else, and that's what you have to be on. So I just think terminology is extremely powerful and important. Dr. V?
Okay, so all this to say that a recovery-oriented system of care is really what we're looking for, right? That would be, to us, what is the gold standard? And we're talking about medication-assisted treatment, which our programs are for treatment of opioid use disorders, but also all polysubstance abuse and all substances. You really do need that combination of medication, counseling, structure in the environment, integrating medical, psychiatric, and addiction treatment, and then everything that happens in the community, right? So, is DCF involved? Do they have legal issues that are pending? What's the relationship with supportive family and friends? Educational services. These are all the pieces that go into that. I know Melina is going to talk about that a little bit later on, but Melina, how do you bring in all of these pieces when a pregnant woman comes in and is asking for help? how do you consider the recovery-oriented system of care and how do you address it?
So we address it for the most part based on where they're at. That's how I do it. I just gauge with the client and work with the client and take things step by step. So I know when they're at the hospital, sometimes I'll do family sessions and we'll work on that and building a recovery support system. And then if DCF is involved, I'll reach out, make connections and get that situated. And then with medical care, obviously it's easy because I have a connection with the physicians at the hospital and we're able to coordinate OB care, maternal fetal medicine. So it's just like building a puzzle is kind of like how I do it.
And you don't, like, as you're working with somebody and they're more comfortable, you get to know more things that are going on, and then you start to have to bring in other pieces.
Yes.
Thank you for that, Ms. Molina.
Thank you.
So now, we're going to talk a little bit about our Mothers in Recovery program. How are we doing for time? Okay, so we're at 2 o'clock. This is right about where we wanted to be. Do we need to stop for any questions before we get into this part?
The only question was if the slides will be available and sent out.
I sent them to you guys.
Yeah, we just wanted to make sure that we could just send them to the
Distribute.
helper.
Can you, do you want me to, I'll send it to you as a PDF so that you can distribute it easier?
I can make it a PDF, no problem.
Okay, that would be great. Yeah,
Thank
Thank
you.
you.
fantastic. Thanks, guys. That's the only question? I'm amazed. Okay, so we started the, I mean, Alberto, you want to introduce our Mothers in Recovery program?
I'll let you take that lead. You're better at the vocal part.
All right, so we started Mothers in Recovery in 2015. The BBHC, the managing entity, approached our hospital system. I think it was like mid 2014. I think it took us about 6 months, I think, Alberto, to kind of work on all the literature review and everything that we put into it. Basically, at that point, Palmetto Hospital had closed. Palmetto Hospital had a 30-day methadone program for pregnant women. And they had closed their doors because I guess I'm not really sure. So what was going on, and then it was Susan B. Anthony, and a pregnant woman using heroin is trying to get help, and she can't go into Susan B. Anthony because she's testing positive for heroin. No hospital is going to treat her because she's pregnant. And so, you know, it was a real problem in our community. So BBHC came to us and said, hey, what would you like to do? We have this issue. Can we start a partnership between Susan B. Anthony and Memorial Healthcare System? So at the table was Dr. Ogston. We had Dr. Lori Scott, who is she's the medical director for maternal fetal medicine for the healthcare system. She had worked in a hospital in Texas where they had actually detoxed pregnant women. So at the time, that was way before MAT was something that was talked about very often. And the goal was that the women would get started, and we had an option. We could have used methadone, but decided to use Subutex or buprenorphine for various reasons, which we'll get into. And then we had to, in order for them to stay at Susan B. Anthony, we had to detox or do medically assisted withdrawals, so detox of pregnant women off of the buprenorphine over time so that then they could transition into the full residential program at Susan B. Anthony. So a couple of, how do we get women started? How do we make sure that we are detoxing them safely? And then obviously working with the community. So all of these were factors that we considered. And the only way that we could do it is really taking a system-wide approach with the healthcare system, going beyond the hospital walls in our relationships with other community providers, including Susan B. Anthony, and making sure that we looked at mom and baby as our patients. It wasn't just a pregnant woman, but it was a woman and her baby. The other thing was we couldn't just focus on opioids. It was important that we looked at all polysubstance, because I want to say, and Alberto, you're better at the stats, but like 99% of the people that we've served in this program have had more than one substance, had been using more than one substance, correct?
Yeah, and that's old data. So imagine today.
Yeah, exactly. So for us, the main goal is how do we reduce the rates of neonatal abstinence syndrome? Because we know that babies who are exposed in utero to illicit drugs are born with neonatal abstinence syndrome. How do we promote maternal recovery? So for mom to just truly create a program of recovery from substances, looking at recovery-oriented family environments, making sure that our approach was integrated and multidisciplinary, and then looking at its impact on our system. Is this something that was going to be very expensive for us to do? How does someone move through our very complicated, sometimes hospital system, so that they can get the care that they need? And those were the things that kind of went into how we developed our program. Dr. Austin, would you like to talk about the standard of care?
Yeah, I'll talk about it a little bit. I don't know if you're going to add what happened with the original cases when this first started 40 years ago. But essentially, our standard of care, my math is a little off, almost 45 years or so, of inducting individuals who have an opioid use disorder in pregnancy on methadone. And it stems from a need to maintain them because of the fear of death of the neonate, subsequent withdrawals and risk of death in neonates. Now, that stems from a particular publication that occurred back in the 70s that informed the practice and created what we see today and have been seeing. That has been challenged on numerous occasions and for over a decade. And even with that challenging, it was extremely hard for even us to get off the ground. But when you look at it, when you look at the standard and you look at the utilization of methadone, and Dr. Vicencio mentioned the ability to utilize buprenorphine, there is now clear rationale and evidence to support the use of buprenorphine. Not only is there clear rationale and the potential better outcomes of buprenorphine specific to risk. And risk, when we talk about risk of neonatal abstinence syndrome, risk of length of hospital stay, and a variety of other factors. There's even risk associated with the degree of how the fetus is experiencing methadone versus buprenorphine. There's even evidence to support that that is a reality. And I'll give you a little bit of education on this. As one is inducted onto methadone, one of the understandings is that, and you might encounter this in some of your patients, methadone needs to be titrated and titrated up until the patient stops exhibiting signs of withdrawals and cravings. That ceiling does not exist, meaning there is no max dose for methadone. Hence why you might have individuals who are on methadone as high as 160 and as high as 200 and so. One of the understandings is that whatever you give to a mom, a percentage of that is actually passing to the fetus. That alone should make you understand. As you titrate that methadone up, let's say it's 10% of whatever your mom has is going to the fetus. Imagine how much is passing to the fetus. That's not necessarily the case with buprenorphine because buprenorphine has a ceiling effect, meaning you can't go above a certain amount of buprenorphine, right? It's maximized. Because if you go beyond that, it actually causes opposite effect. It blocks the receptors. So just that simple fact tells you that there is a stark difference in either of these agents. Dr. Vicencio?
Yeah, so basically there had to be a change in the way that we approach treating pregnant women. And our program has been controversial because of the fact that we did use buprenorphine instead of methadone. But since we started in 2015, there's been really good research to show that you can use buprenorphine, and actually methadone is toxic to the baby or can be neurotoxic to the baby, as Dr. Oxen was saying. But then you can also detox pregnant women if you have them in a structured environment, if they're getting support. And there's even a lot of really good research out of Tennessee that intensive outpatient services works, as it doesn't have to be a residential program. So the idea was just, you know, anytime that you're doing innovation, you're going to get a lot of pushback because people do things the way that they're doing them. But, you know, we were practicing medicine now for the treatment of cardiac conditions the way that we did in 1970, you know, there would be a problem with that, right? So, I mean, we used to always tell the story. Basically, somebody comes in with a heart attack and you would watch them and see what happened. Now we obviously have a lot of, you know, different interventions that we use. And so this is what we're getting at here. Okay, so really important though, if we're doing something innovative or we're putting all these different issues in place, there has to be collaboration and coordination in the whole system, all of these other pieces. Melina, would you like to add here?
No, that's it, because it goes into the next slide about, I think that's, yeah.
Take it away, lady.
All right, so basically what I try to do with the help of my team, because I don't do this by myself and I wouldn't be where I'm at today without them, is engaging the client when they come into the emergency room and making sure that they stay for the course of the treatment. So once they're into the ED, they'll do initial OB workup and they'll also see the physician. And then they'll stay inpatient for about 7 to 10 days. And in that time, there'll be peers that go and reach out to them. And then if it was a referral that was made, I will collaborate with the person too that made the referral to see if they want to continue to engage with the client and keep them motivated for treatment. And I will also do individual sessions myself when I go meet with them. And then there's psychiatric and medical stabilization, and then obviously setting up any type of outpatient resources and support. So at this point, I'm also connecting them with Medicaid, medical appointments, setting up appointments with OB, any referrals that they might need for other services. And then depending on the case would be what the discharge planning would take place. So if they have a stable living environment, I would discuss with the family about coming to outpatient services. If they don't, then we would reach out to other agencies in the community or some type of supportive housing so that they can attend treatment. And if not, sometimes residential treatment is the option. And that's it. It's a lot of stuff. And then this is the order set in the emergency department, right, Claudia?
Yeah, so Dr. Austin, would you like to talk a little bit about how we sort of optimize the process by using our order set?
Yeah, for sure. So for the folks that are on the line, and once again, we thank you guys for listening in, and you guys are so quiet. I wish we would have more people talking, but anyways, I respect it because it's a lot of information. But I would say the following: when you ask yourself, how is it that this program, right, can tie up loose ends? Meaning, what if a patient presents and it's 2 a.m? What if they presented it's a Saturday midday? Well, this is how we address that. So the beauty of the improvements of technology is that we have what's called an electronic medical record system. And it allows us, we use something called Epic, and our entire system is on Epic, and many systems are starting to adapt to these different programs. And it allows you to create what are called order sets. And the beauty is all we have to do is educate, and we did this already. And you tell everybody, you've educated the providers, physicians, nursing staff, and so forth. And you say, it doesn't matter if you are pregnant and you're using a substance. They don't even have to know it's an opioid, because as you could tell, there are many things people are using, right? The approach is the same. The fact that the opioid we have, buprenorphine and methadone, doesn't matter. The same approach for any substance use. We engage them and we activate the system, which is this order set, and it activates the entire team. And it pulls us into this process. So that's the benefit of having this order set, making it 24/7, 365 days a year. Because at the start of the program, Dr. Vicencio and I were getting calls at 2 a.m, on a Saturday and say, hey, we have a patient who just presented. What do we do? Now that's gone. Now it's a system in place. It's automatic, and there's no harm to baby, no harm to fetus, and we're engaging anybody that wants the services and treatment. That's the way I really describe the system.
Dr. Ogston, can we, there was a comment in the chat that I think is a good thing to address because it does come up very often in our system of care, from Nicole about the moms on methadone not being able to access other kinds of treatment and recovery supports.
Okay, so you want me to address that?
If you can, yeah, and I could talk
Just a
about
lot
it
of
all
mothers
day.
are being prescribed methadone and they cannot get into a mommy and me program because most will not take mothers on methadone. Okay. I want to address it two part. I'm going to address the first part and I'll let Dr. V take the second part. I'll address the part of the drug itself, which is there originally was a thought process. It's very difficult to transition somebody from methadone to buprenorphine. We created a protocol to doing so, and it's actually rather easy. Moreover, there's no limit in dose. Before, a patient had to be on 30 milligrams. Think about this service. A 30 milligram dose is a dose that somebody is probably on day one. After day one, day two, those patients are probably on 50, then 70, then 90, then hundreds. So the answer to that is many of these moms can transition from methadone to a buprenorphine product, which is actually also beneficial long-term if you're not pregnant, right? It's actually beneficial. But Dr. V will answer about the programs themselves and the limitations.
Yeah, so I mean, I think what happens with that is that I don't know like about community programs not taking, this is actually the first that I've heard, but what happens, the reason we chose buprenorphine over methadone is because we wanted to be able to make sure that we could integrate that treatment, right? So if somebody, that we were able to manage that. What happens with the methadone is that the pregnant woman has to go to a methadone clinic. That's the only place where she can get it. And a lot of times that can be prohibitive in terms of it's cash only. So that's the way that they, they typically don't take insurance or Medicaid. So the mom has to go get the methadone. Sometimes it's a transportation issue. Sometimes it's how long they have to spend at the methadone clinic. Do they get take-home doses? And then how is that methadone clinic integrating with the OBGYN? Is there regular communication going on? Are they testing them for other drugs? And if there's other behavioral health conditions going on, other mental health issues, other medical issues, how is that being addressed? And so I think the nature of the methadone clinic is that, it's sort of siloed and it separates that piece out, that piece of the mom's care from everything else. What we've seen in practice is, we've had some, like Dr. Olson was saying, we've had some women on methadone come into treatment with us to switch over to be inducted into buprenorphine. Typically when they come in, the women that we've seen have been highly sedated. And I think that has to do with what Dr. Arkson was saying, where as the pregnancy continues, that they're prescribed higher and higher doses of methadone. And so like, you have a woman like that in a treatment program and she's literally nodding out in front of you, that could be triggering to the other people in care. So I think that those are some of the factors. I don't know, Melina, if there's anything you want to add to that or if anybody else has anything that they want to add. Hopefully we covered it. I'm sure there's a lot more to say, but and I think that, there's a place for methadone. And I think that there's other communities where methadone is used a lot more. What we found in Broward County is that, buprenorphine is really the standard of care for us, especially in the treatment of addiction and pregnancy. Okay, so I think we use this slide and it talks about all of our different programs. Basically, when we designed MIR, and I think one of the things that we often don't talk about, but right before Mothers in Recovery, Dr. Oxen put out this long-acting therapy clinic, and that's really for the treatment of thought disorders or bipolar and schizophrenia with long-acting injectable medications. And at the time, it was really innovative because this is a medication that's really important. for the treatment of thought disorders. It's sometimes not accessible because a lot of places won't prescribe it because they don't provide the injections. And so the Lung Anti-Therapy Clinic was really sort of the beginning of this idea of thinking outside the box, innovating, and then doing things that were integrated with not just one provider doing one thing, but really working within the community. So that was the prequel to MIR. But once we started Mothers in Recovery, it really was about bringing in the behavioral health, the counseling piece, with the medication piece, with medical, with community, and then with addiction services, all of those things together. And we use that blueprint then to create other programs, such as, medication assisted treatment for the general population. Looking at our emergency department engagement program. When we started Mothers in Recovery, we didn't know how a pregnant woman should come into care. It took us a little bit of trial and error to figure that out. I think our couple of first starts were a little bit, we had women on the medical floor, we had somebody coming in through outpatient services. We quickly found out the emergency department was the fastest way. Why? It's accessible 24/7, 365. So as long as our emergency department staff, physicians, nurses, they understand what the program is, they have the right education and resources. Ideally, a pregnant woman or anybody seeking treatment can come in at any time into our emergency department and access that care. And so we've been initiating Suboxone in the emergency department since 2017. We were doing a pregnant women before that, obviously, but with the general population, since MAT services started in Broward County, we've been doing it. So this is just sort of this idea of integration. These are all the different services that we have. Alberto or Melina, anything to add to that? I'm gonna say no, and then we're gonna stop for questions, and then we have a breakout. Anybody have questions?
I have a question. What is the maximum amount of buprenorphine? What's the cap that can be prescribed?
Good question.
Can
You
you
wanna take
repeat the
that?
question? Can you repeat the question, Stephanie? Microphone, I think is something I couldn't understand the question. Can you repeat it, please?
Yes, so the question is, what's the maximum amount of buprenorphine a patient can be prescribed?
Yeah, I'll touch on that. I mentioned earlier there's no max for methadone. And somebody wrote in the chat, most moms are on 200 or more that I encounter. I've seen that common. There's no max on any opioid that acts purely on the receptor. The max is secondary to what you can handle physiologically. So your body can handle X amount. Hence why if you give somebody fentanyl, you can handle it, but it gets to a point where you die secondary to respiratory depression, right? So that's important to know, because your pain receptors may need more or theoretically need more because of some psychological addiction you're creating, but your respiratory related drive still will have negative consequences at certain levels, hence the danger of purely increasing an opioid. Now, the beauty of buprenorphine when it came to market is that it acts like a partial agonist. We didn't go over that, so we're a little bit complex. Partial agonist. Typical opioids are what we call agonists. They hit the receptor. Partial agonist hits the receptor, but at a certain dose, it actually blocks the receptor. Okay, and actually it's more powerful because partial agonists not only hit the receptor, but if you have another opioid there, like let's say methadone, morphine, fentanyl, it goes in and actually removes it. Hence why, I'm sure you guys are aware, if you start buprenorphine too soon, you can induce withdrawals, right? And you can master that because you need to wait X hours since the last dose, then you can initiate buprenorphine. Now, related to ceiling effect, that means the majority of patients, majority. When we talk about majority, if you want to do statistics, majority implies 99% of the population potentially, if you do something called 3 standard deviations. Now, there are people that are going to fall away from this. There's some people that have unique profiles and receptors. The majority of patients will not be able to handle any more than 20 milligrams. Why? Because above 20, it starts actually blocking the receptor. That's the theoretical ceiling effect. Now, I would tell you, the majority of our moms, regardless of what they came in on and what they've used and the amount they've used, over 150 moms, majority of our moms are on no more than 8 milligrams of Subutex buprenorphine a day. 8 milligrams a day. So just kind of put it into perspective. Melissa has a question?
Yeah, what about naltrexone? Can pregnant women take that?
Excellent
Great
question.
question.
Excellent. So naltrexone is an agent that acts like an opioid receptor antagonist, completely blocks the receptor, completely blocks. Naltrexone is the sister of naloxone. Naloxone is what we're using in Narcan to reverse people who have an opioid overdose. Naltrexone is similar to naloxone. The one difference is that it has a longer activity, so it doesn't kick in fast enough, hence why you wouldn't want to use it to save somebody, because it'll kick in maybe hours later. And moreover, now it's available in an injection form that lasts 30 days. Now, the answer is most people originally thought, talk about standard of care, that no, it's not a good thing. However, there is a physician out of Tennessee that has a very large population that he studied this with, and he actually pulled placenta data, and it turns out that it has really good outcomes. So to answer your question, I think that's going to be the next thing. Regardless, it should be one of the tools in our arsenal, but it's something that hasn't gained mainstream acceptance yet. Angela?
Hi there, sorry. So I just had a quick question. I'm actually a labor and delivery nurse, and through my 11 years on the floor, I just noticed, and I don't know if you're seeing this on your side too, but I feel like a lot of the girls that are starting off on Subutex or methadone, they should be tapered off. And I feel like they still kind of start the same, like kind of where they're at, they sort of stay like that throughout the pregnancy. But it was always my understanding that it's better to try to taper them off, you know, and hopefully to have them to a very minimal or off the dose by the time they deliver. Do you agree with that as far as pregnancy goes, or do you feel like it's better to not taper until after they deliver?
Excellent question. Let me speak to that. Excellent question. So this is the way I look at it, and you have to come from a ROSC-oriented system of care, right? So why is that important? Because it's patient specific. Who are we to tell a patient what they should or shouldn't do? And it has to be black and white facts. So there has to be options. However, the education study should include to say, we have the opportunity to taper off before the baby's born. Why would you maybe want to do that? In populations in which you have comprehensive care, wraparound services, safety in place, a mechanism in case you use, we don't want you to use and overdose and die, because that's the concern, death, right? Now, in that population that can be engaged as such and are candidates, tapering is possible, and we've had high success with that. Moreover, it's not only possible, it's safe, and it leads to babies that are born unexposed, right? Post termination of the use of the product. And it leads to decrease in length of stay. It leads to decrease in NICU days, and an increase to positive outcomes long-term. So to answer your question, the answer is yes, it can be done. And if it is going to be done, hopefully it's done before the 30-week to 33-week mark in the baby in terms of gestation. Now, it doesn't mean it has to happen before 33. We've done it later than that. But the earlier you can do this, the better, specifically for outcomes in the mom and the baby. So hopefully that answered your question. The answer is yes.
It did. Thank you very, very much.
That's something I'd like to add to that is in our program, we do taper people off the buprenorphine completely. We also start on low doses of buprenorphine. So we will start on the lowest dose for pregnant women and for the general population. That is, the person is still comfortable, that they're not experiencing cravings, but it's not, a lot of places or sometimes private doctors' offices that prescribe Suboxone or Subutex start with high doses to begin with. So then it's a lot harder to bring a person down or to slowly taper them off. I think there's another question. Is there? No? Okay. And then just in terms of tapering people off, I think Dr. Oxton really said it well, which is, patient choice, what's going on in the person's life, what are some of the things that need to be considered. And I would look at also as treatment providers, what's the person's trauma history, right? If we're coming from a trauma-informed perspective, being told what to do or how you need to do it or how you need to birth your baby or what medications you need to be on. If you've been told that, different things like that your whole life, I think people need to have a choice. So I think it's important.
There is one last question, I think, on
Yeah.
the chat. Has any of the treatment affected the babies in utero, or were they already affected due to mom being on substance already? And I'm assuming they're asking for the treatment with buprenorphine and methadone potentially. And the answer is, so the way you have to look at it is you have to evaluate a few things. Number one, you evaluate the rates of birth defects in utero and recognize that there's a standard rate in the general population, regardless of any substance or exposure or unexposure. There's also a standard rate of stillbirths and deaths. It's still happening. And actually that is a quandary. Why is it that a country like ours has the death rates we have? It's still a quandary. And this isn't healthy moms. But now if you separate that out and you say, all right, now I have this standard data, and you see the utilization of buprenorphine and methadone, you actually have positive outcomes. Now, comparing methadone and buprenorphine itself, one of the main things you look at is length of stay. So you have decreased length of stay with buprenorphine, decreased length of stay if you detoxify completely correctly. Then it comes to NICU days, decrease with buprenorphine, decrease if you detoxify completely. Then it comes to growth retardation. Growth retardation is extremely important because it can be a measure of the health of your baby. Just think about it. If you have a baby that's born at 4 pounds versus 7.5 or 8 pounds, you would imagine that the development of main organs is different. And sure enough, when you change from somebody who's using to methadone, you have similar growth, meaning growth retardation is still there. However, when you switch to buprenorphine, growth retardation decreases significantly, meaning the baby then goes on to develop fully in utero, right? The growth, and you see this. You see them on buprenorphine, and all of a sudden you see that their bellies start getting very large and big, the baby's growing, and it's a clear sign of health. And then those babies are born healthy as well. And then lastly, comparing somebody, and they look at what's called APGAR scores. I'm sure you're aware of this, and anybody who's had a baby. When the baby's first born, they're checking respiratory rate, how much they're moving, instability. And those on methadone are similar to those on heroin, in which those scores are reduced, hence why they're classified as NAS babies and need NICU days. For buprenorphine babies or those in a program detoxified, you have lower rates of having that issue. So that's kind of how we assess those things.
Okay, would you guys, should we take, Stephanie, do you want to take a 5-minute break and then we'll come back to the breakout sessions?
Yeah, that sounds great. So
Okay.
be back in 2:37.
Okay, that sounds, let's make it 2:40.
2:40. Okay.
All right. Okay, so we're about to get started again with our case study, and we're gonna have Melina go ahead and present. Stephanie and Sam, do you think we're ready to get started again?
Yep.
Yes.
Let's do it.
Okay, and then once we present the case study, we're gonna give you some discussion points to go over in your breakout rooms. Okay, Melina.
Okay, so Penny presents to the emergency department, and she's a 40-year-old white female, self-referred to the MIR program, and has been trying to get some type of substance abuse treatment. She's currently 19 weeks pregnant with her first pregnancy, and she's currently using IV heroin, crack cocaine, and cannabis. She's currently homeless and living on the street with her boyfriend, who is physically and emotionally abusive towards her. Penny hasn't had any prenatal care or any type of medical care, and originally when she presented to the ED was because of some medical condition. That's it. So you have my job. You are assigned as her navigator. What is your first step? And then the second thing is to identify 3 potential risks to mom and baby. And then also identify 3 areas of clinical concern. And finally, we need to develop a plan to keep her engaged and in care throughout postpartum.
So Stephanie is writing them in the chat, and if you want to go ahead and just like take a picture with your phone, whatever is easiest, but we're gonna send everyone off into breakout rooms, and you know, the theme of this, you know, Dr. Ogson reminded us earlier that we want to always ask ourselves, you know, what can we do better? You know, what are we doing? You know, how do we do this, and how do we really push the envelope? So that's why we wanted to really bring this to everyone's attention and give everyone, you know, a chance to really talk about like what would we do? So Steph, you want to send us out? Oh,
Yes, I'm gonna make the breakout rooms.
yeah.
There'll be 15 rooms, and please make sure, we're gonna try to set a time limit, but if it doesn't work, please be back in the main room by 5 till 3 so we can discuss and then send you all on your way. So
Claudia, can you just go back one slide so they can take a picture of the case study?
Oh, hold on. I don't know what happened there. Hold on. Yeah, 1 second. I don't know what just happened. Okay, this is the slide. Yeah.
Yeah.
Yes. Thank you.
That's it.
Okay, hold on. Okay, this is the case. So she's 40 years old. She's 19 weeks pregnant. This is her first pregnancy. IV heroin, crack cocaine, and cannabis. Homeless, living on the street with her boyfriend, who is physically and emotionally abusive, and she hasn't had any prenatal care. She didn't actually even come in for the treatment of addiction and pregnancy. She came in for a medical condition, but now she's here, and you want to make sure that you're addressing these points when you guys are talking. Find someone to speak for the group, and then just kind of brainstorm based on a lot of the stuff that we talked about today, how you'll do some of these things.
all right, the breakouts are starting.
Did we do it? No.
Okay, hold on, I see it. 10 minutes, we're gonna do them.
Did Tina Hudson get the scenario back up?
Yeah.
Did Tina Hudson? Yeah, you got it, Tina? Okay, good.
Okay, you should see now a thing, accept it, and go to your room.
I don't see anything yet, Stephanie.
Steph, something's wrong.
Okay, hold on, we'll try it again. Okay, there we go. Now did it go? Yeah, they got it. For those of you that are still in this main room, oh, there you go. It should be prompted on your screen to join a room. If you could go ahead and join them now. Adriana, did you see the room assignment on your screen?
Don't worry about it.
Okay, so we should enter a room just to listen in. So who's going into what room?
I don't care. I'll go wherever.
I'm just gonna go in one that doesn't have that many people because it didn't assign me to one.
No, I know because you're co-host, so we did exclude the co-host.
Yeah, room.
Yeah, that's fine. I'll just jump in one.
Okay. Which one? So we don't all go.
How do you get in to one?
You click the join. It'll say it on the top right on the.
Oh, can I ask you a question? Does this part record? Yeah, okay.
If you click, like, it'll show you which one, Sam, like it'll say room 1, 2, and then you can just click join on any of them.
Where do I see that? Oh,
At
breakout.
the bottom, it's next to record.
I see.
I'm gonna go in room 3.
Okay, I'm gonna go in.
I'm going in room.
I'll go
14.
in 5.
Okay. See
5.
you soon.
Potential risk. Hello? Go ahead, Diane. Okay, identify 3 potential risks to mom and baby.
Overdose for mom, death, fetal growth restriction, HIV.
HIV. What else is here? This is mommy's first pregnancy using IV, heroin, crack cocaine, and cannabis. Homeless and living in the street with the partner that's physical and emotional abuse in no prenatal care. Hello?
Some people are here, Diana.
Okay, I don't see.
It looks like some people are multitasking. Anyone want to spend the last 10 minutes of training answering some of this? Does anyone have any thoughts on this?
And another risk could be that the baby is going to be born with some kind of birth defect based on all the drugs that she's taking. And since she's on the street, also like things could happen to the mom while she's on the street, like so that's not safe. That's another risk.
The element of being in a different relationship and homeless also need to be addressed.
Elements of being homeless.
An abusive relationship.
Yeah, well, if she's, yeah, I mean, to me, the thing that stands out is if she self-referred herself into treatment, but is in this, you know, control dynamic relationship, that the chance of her leaving treatment is very high.
So a good plan for her then would be maybe just like bi-weekly follow-up or like every other day, just to make sure that she's staying engaged in her therapies and everything.
Yeah, and to reach out to her supports, right? To engage them into the treatment process, right? And it might mean dad, engaging dad in the process. I mean, if she's, depending on how she wants to, if she wants to continue that relationship.
I believe we had a similar case a couple of weeks ago, right, Samantha? That the father was already in treatment for 20-something days and we were trying to engage her, the mom, to get into treatment.
Yeah.
But so it could be something similar. Try to, like you said, engage the father to take the treatment. And then can the mother go to Village South? Or no, because she's doing heroin, I believe.
Well, the scenario started that she self-referred herself into Mothers in Recovery. So she's linked up with starting the treatment process.
Mm-hmm. But the program at Memorial doesn't have any housing, it's just a clinic.
Right. So it's about a plan of stabilization and then, you know, what level of care of treatment is, you know, they're going to recommend.
Okay. And this is her first pregnancy, so she doesn't have any other children.
Right.
She also is a world that make her at risk with being an AMA mom.
Yes, she's 40 years old. Anything else?
I'm going to go back into the main room, so we're ready to close up, okay?
Are we all back?
Almost. Yep, we have 117 people back.
That is, by the way, a like amazing turnout, you guys. What do we have, like 100 and 120 something people on here?
Yeah.
What? That's amazing. Amazing. And that's a tribute to you, Stephanie and Samantha, for putting all this together. I know how much thought went into it.
Well, we couldn't do it alone, that's for sure. So
I see a question. Oh no, that's just my hand. Never mind. So we're gonna just wrap up at this point. You're gonna give them instructions for next week, right?
yeah.
I don't know if Melina, you want to close us out, or Dr. Oxton, just to say some final words. Sam, you were going to say something?
Yeah, is there one group that wants to share for like 1 minute before we, is there anyone that wants to share? Or Melina, is that what you were gonna say?
I'm sorry, are we meeting tomorrow or next week?
She meant tomorrow. She meant
okay,
tomorrow.
okay.
Yeah.
All right, no problem. Thank you.
Tomorrow, we'll give you all the details in our closure, but so if there's no one that wants to share, we hope that few minutes, just to really, I know for the group that I was in, it wasn't all too easy to really come up with, a plan and all this, we talk about it all the time, we see it all the time, but when we're faced in that, in that circumstance, what do we really do?
I can do one, Sam.
Oh, great. Sure. Go for 1 minute, Matt.
Okay. So starting out with the first question, what is the first thing that we would do? We stated that we would meet with the mom face to face. Most likely she'd already be at the hospital since she's self-referred to MIR. We find out the last time that she used to identify the appropriate intervention, and have her complete drug testing, Hep A, B, and C, and HIV or AIDS testing, to identify any other risks that we may not be able to see or that the mom could tell us about. The next thing, we would identify 3 potential risks to the mom and the baby. And in my group, we kind of agree that these 3 also coincide with the 3rd step, which is the clinical concerns, like overdose, death of the mom and the baby, neonatal abstinence syndrome, NAS, birth defects, low birth weight, preterm labor or miscarriage, and losing custody whenever she does give birth. The appropriate interventions could be used clinically, and develop a plan to keep her engaged and care through postpartum would be to go to the Village South. Since she's 19 weeks, she has about 20 weeks until she gives birth. If she gives birth, naturally, and we could help through that program. She would be able to obtain housing before she gives birth, hopefully after 6 months of treatment, and then have somewhere to be with the baby before getting out of treatment. Identify family supports, batterers intervention, and any other counseling or anything else that's recommended. So that's it.
Awesome, Matt. Thank you so much for sharing. So thank you everyone for participating today. And especially thank you to our memorial team. This information that you provided us will hopefully give us a new understanding of how we can continue to better support pregnant and parenting persons that are experiencing substance use. The information you provided is absolutely invaluable to the work we do. So this concludes our day 1. We hope that everyone will be back here tomorrow. The same Zoom link is how you will access session 2. It's the same time, it's from 1 to 3, and it's an action-packed day with live stories. So we hope to see you all there. Thank you.